Lee speaking to us about developing critical care in low and middle income countries through medical education. I reached out to Dr. Lee because, as a lot of you know, we have made a push to expand our own involvement in critical care from just the city of New York to really starting to look at how we might be able to reach out and work with other groups throughout the world in growing critical care. And so I just want to give say a couple words about Dr. Lee's illustrious career. Dr. Lee graduated medical school at Harvard and did his pulmonary critical care fellowship at MGH. Initially, he was the director of the NICU at MedStar Washington, where he was also the director of the pulmonary critical care fellowship there. While at MedStar, he co-founded the Baltimore Critical Care Consortium. And then from 2010 to 2016, he spent time at Abcde Hospital in Kenya, where he co-founded the Emergency Critical Care Clinical Officer Program, which was the first clinical officer training program of its kind in sub-Saharan Africa. In 2016, he returned to the University of Pittsburgh, where he has since been involved in medical education. And in 2020 joined the NIH as the head of medical education and now the head of global critical care there. So I hope all of you will join me in welcoming Dr. Lee to talk to us about critical care in the international setting today. Thank you, Dr. Lee.
Can you all see my slides? Okay. All right, well, thank you, Dr. Lay, and thank you, Dr. Gidwani, for your warm welcome. And again, it is a real pleasure for me to be here. As you just heard, I feel like I have this, this dream job at the NIH as the head of medical education and head of global critical care, which are the two areas of passion that I've had throughout my professional career. So, so I'm really excited to be in this new role, and I hope to tell you a little bit about the work that I've been involved with in the past, but also some of the things that I hope to do, and then perhaps some of you may be interested in actually collaborating together, with our future endeavors. So, so I'm delighted to talk to you this afternoon about developing global critical care in low and middle income countries through medical education. I want to take you back, I guess, roughly 11 years now of how I ended up with some of this work. In 2010, I had the great fortune of having a sabbatical year. And during that sabbatical year, my thoughts were to go to a low middle income country and to help in the development of critical care. Both clinically, but also educationally and research-wise. So after some research, I decided to go back to a place where I spent actually 3 months as a medical student, which was about 10 or 11 years before that. And so I went to a place called Kajabi Medical Center, where I did my medicine and surgery rotations as a fourth-year medical student. And I remember, just really falling in love with the place and with the people. So I thought it'd be a good place to return to. And the hospital was also starting an intensive care unit there, and they were looking for some help for further development and growth. And so I thought it'd be a good fit. So in 2010, I actually packed up my whole family for the sabbatical. So my wife and our 2 children moved with me to Kenya. But I think this is probably one of the more important points that I think I'll be saying is that 1 year turned out to be not long enough. 1 year is a lot of time. So I don't mean to discount that effort, but it turns out that at least in my situation, to really make an impact in this setting, I think I needed to have learned a lot myself first, and to maybe throw out some misconceptions that I might have had, and also to get a deeper knowledge of the culture and how people think and behave in a different setting. And so, so even 6 years, I can't say that I mastered those things, of course, but at least, I got a deeper appreciation for how a different culture works, how a different culture behaves, and especially in context of clinical care that requires a change in how doctors and nurses might relate to one another, and how doctors may relate to patients, and how how different resources are actually thought of in a different cultural context. So all of that is to say is that I spent probably the first 3-4 years of my 6 years really learning and having lots of chai. Because at least in Kenya, not much happens without chai, and so you have to have lots of times getting to know people that you're hoping to learn from, but also to eventually influence for clinical changes and for administrative structure. So the first 3 or 4 years, it was much about me just trying different things, but mostly learning from my colleagues in Kenya. And then in the last 2 years is when we were able to actually start a program that was in developing medical education of clinical officers in emergency medicine and critical care. So I have to tell you a little bit about that experience. And I should preface by saying, my experience, of course, is one of going from a high-income country to a lower middle-income country. But since there's a lot of diversity in low middle-income country settings, I'm not sure that everything I experience is necessarily generalizable to every other low and middle-income country. But I think it's at least is a reflection of my own experience, and I hope some of this will be useful to you if you're thinking about doing this or if you're already involved in this. So let me tell you a little bit about the setup. What made my 6 years work there was, we lived in a pretty idyllic setting, I would say. We lived in the Great Rift Valley. And if you're not familiar, the Rift Valley starts out in South Africa, and the valley cuts through much of the continent, actually toward Israel. And the valley is where, like you might imagine where the cartoon kids movie, the Lion King took place, where down in the valley would be all the animals and so forth. So we lived on one edge of the escarpment. In our case, we lived on the eastern edge, and you could look down at the valley, and it's quite a beautiful setting. And we also lived about 8,000 feet high, and the relevance there is that that's above the malaria belt. So it made it more tolerable for us to live there, not necessarily having to take malaria prophylaxis on a daily basis, although we did have to do that if we traveled outside of our region. So we're about 1 hour and 40 minutes outside of Nairobi. You can see a map of Kenya here with a star indicating Nairobi. And then Kajabi is that little red dot about northwest of Nairobi. So if you look at a satellite map, here is the hospital here. And then I actually lived maybe about 100 yards away at a house that looked like this. And then our children actually went to the school called Rift Valley Academy, which is again about 100 yards up the hill. And so it was a pretty nice setting for our family to spend time. And actually they enjoyed the time as much as I did, which is what allowed us to stay for 6 years. And then we actually returned from Kenya back to the United States when the younger of our 2 children actually graduated from high school there and then was about to start university. And I realized at the end of 6 years and our kids at university, I realized that the American universities are not free. And so at that point, I needed a real job to help pay for college. And so that's when I moved to the University of Pittsburgh in 2016. So the major things I was involved in, of course, I was involved in clinical care, but a larger portion of what occupied my mental bandwidth is actually in resource capacity building for the future, but also in terms of research capacity building, where you're involved in teaching things like biostatistics and research design, and then to help those interested to a higher level of research engagement. And then the other area was in clinician capacity building, which is to build up other clinicians so that they can take better care of the critically ill patient, whether it's in the emergency room setting or in the ICU setting. So I want to focus primarily on the education, either it's clinical education, but also in terms of research education. So this is a nice diagram from the New England Journal of Medicine, which I'm sure many of you are already familiar with, which actually charts on the x-axis the number of clinicians that exist per 1,000 people. And so these are doctors, nurses, midwives on the x-axis. But on the y-axis are the clinical burden, the daily, the disability adjusted life years per 1,000 people on the y-axis. And then the sizes are it's the distribution of the clinical workforce. So as you can see here, the Americas and Europe are pretty high in terms of supply of doctors and nurses, and relatively low in terms of the disease burden. And of course, as I'm sure many of you know, sub-Saharan Africa is off the charts essentially in terms of the disease burden, but it only has about 3% of the world's clinical resources in terms of clinician supply. If you think about the same topic slightly differently, here is the number of physicians per 100,000 people in the US. It's 549. I think this is it's about 10-year-old information. But in sub-Saharan Africa, in places like Kenya, Uganda, Tanzania, that number is only 2 to 5. So, maybe 1% of what the US has. And so I like this map because it kind of visually shows you, the same information, which is the supply of physicians and other clinicians around the world per size of the population. So as you can see, much of the Northern Hemisphere, North America, Europe, and even Asia is pretty bloated in terms of clinician supply. But much of the Southern Hemisphere, especially Latin America, and even more so in Africa, the continent looks very emaciated from shortage of clinicians. So, that's part of the reason why I went to Kenya, was because I wanted to see, if there's ways that I can contribute to this maldistribution of clinician resources in Africa. Now, I'm sure some of you have thought about this issue in depth, and have thought about how does critical care actually fit into this maldistribution, since I think one could argue that there's a greater need for public health measures and primary care and just basic supply of physicians and nurses. And I think all of that is absolutely true. But actually, in a country like Kenya, it's not necessarily even like the poorest country in sub-Saharan Africa anymore. It has actually been going through a lot of economic development. It's getting closer to a middle income country. And now there is actually a need for more of the secondary and then tertiary care services, including ICU. And then furthermore, I think for the World Bank, they estimate that actually 45% of the death and 36% of the disabilities that occur around the world could be mitigated if there were better or higher level of emergency and critical care services. And so I do think, at least in many parts of the low middle income countries, critical care and better care of the critically ill patients can have a huge impact. So if I drill down Kenya versus the US a little bit further in this discussion, this is data from 2020, which was written in the setting of the COVID pandemic to figure out, how are we doing with physician and ICU bed supplies in the US, and then how does it compare in some place like Kenya. So as you know, the US has approximately 330 million people, and there are about 100,000 ICU beds. In Kenya, it's much smaller geographically, but it actually has 53 million people. So that's about 1/6 of the US population roughly, but there are only 150 ICU beds. And so again, I'm sure you all appreciate this, but there is a shortage of trained critical care physicians in Kenya. And this is in contrast to where I returned to after my time in Kenya, which is the University of Pittsburgh, where one hospital or one building there has 150 ICU beds. And there are many other hospitals in Pittsburgh besides this building that has ICU beds. And I was one of 186 pulmonary critical care or critical care faculty. And so the obvious maldistribution is a serious problem in much of the developing world. So I think many of you are already familiar with this effort. There is an effort in Ethiopia, which I think some of your colleagues have been a big part of, which is the East Africa Training Initiative was started in 2013 in Ethiopia, and they're concentrating on physician trainees. So I think I'm really delighted to see this effort, and I certainly applaud this effort. But we are actually focusing on the clinical officers rather than physicians. And the reason for that is because in Kenya, the clinical officers outnumber physicians 4-to-1. So in other words, there's an overabundance, I'm sorry, I shouldn't say overabundance, but there's a relative abundance of clinical officers to physicians. And especially in a place like Kenya, to become a physician, it's not a matter of just how smart you are or how hard working you are. You also need to have the financial resources to put yourself through school and training, and even if you are very talented and ambitious, you may not have the family resources to actually go to medical school. So we were fortunate to actually be able to identify clinical officers who are, I think the closest thing might be physician assistants, in that they're not physicians, they're not nurses, but they are well-trained clinicians. And so we're able to find those people who have the extra motivation and the intelligence and the dedication to train further in critical care. So those are the people that we targeted. And the program we started is called the Emergency Critical Care Clinical Officer Program, or ECHO for short. We were able to start this on my year 5 of my time there out of 6. And it's a multi-disciplinary effort with people from anesthesia and from emergency medicine and ICU medicine, all contributing to their education in a collaborative manner. And it's a multidisciplinary curriculum. And we had a large amount of support from others from the US who would either physically come to Kenya to help them train, but also to volunteer some resources, whether it be books or like a telemedicine consultation to supplement their curriculum. So let me tell you a little bit about Kajabi so that you have a visual and a mental sense of what it's like. So this is the building I showed you earlier. This is their main hospital. It's owned and operated by the Africa Inland Church, or AIC. Its entire senior leadership, including the CEO, the chief medical officer, et cetera, and the board that runs it is Kenyan. And there are roughly 30 full-time equivalent physicians, half of whom are Kenyan, and the rest are expatriates that come from the US, UK, Hong Kong, Australia, et cetera. And there's a constant stream of visiting clinicians and trainees from high-income countries, again, from Hong Kong, Australia, US, and UK. Some institutions like Vanderbilt University has had a long history of actually collaborating, with the folks at Kajabi, where actually Vanderbilt University supports their anesthesia training program, both their nurse anesthesia training program, as well as a newly starting anesthesia residency program at Kajabi. So part of my excitement for returning to this place is not only because of my personal connection, but because it had a long track record of having a teaching program, but also collaborating with people from high-income countries. So the training program there includes an internship program. As you may be familiar, this is sort of the UK model of physician training, where medical school is 6 years, and then they all do a rotating 1-year internship. So 3 months of surgery, 3 months of pediatrics, 3 months of medicine, 3 months of OB. And most of the physicians at that stage will finish their training and then will start practicing medicine. And so we participate in training interns from Kenya. And then we have residencies, which I think roughly maybe 30 to 40% of the interns go on to. So we have residency programs in family medicine, surgery, orthopedics, neurosurgery, pediatric surgery, nurse anesthesia, and anesthesia programs now. And then we have a advanced practice providers like clinical officers in the emergency and critical care clinical officer program, or the ECHO program. So this is a picture of one of our ICU beds. This is a gentleman actually with acromegaly who is undergoing neurosurgery there. And this is one of our ECHO officers, Bob, who is interacting with them by pointing to a pain chart. And then if you look to the side here on the right, you will notice that there's a small child. And so this is a mixed pediatric and adult ICU. And we only have 5 ICU beds. And so the bed shortage is a real issue all the time. But we have 12 step-down beds for a total of 17 beds for those who are critically ill. And then during my time there, through help of a lot of other colleagues and friends, we're able to do some resource building, including a CT scanner here that you can see, an ultrasound machine, newer ventilators. And so a lot of the mental bandwidth that I was part of was trying to figure out which kind of technology is most cost efficient and actually sustainable for this environment. In terms of education, our learning management system was actually Google Docs, mainly because it's free and widely available. So we set up our curriculum on a Google Drive here with reading assignments with various chapters that you can see outlined here. And we try to provide evidence-based summary of each chapter so that a busy clinical trainee can read it in about 20-30 minutes with a set of questions that they would be expected to be able to answer after reading the material. And then we would meet in person after they read it to go over the topics. And actually, to my surprise, I think the African trainees were actually quite open to having an interactive style rather than just sitting back and listening to a lecture. So here is a group of trainees actually learning about EKGs and their problem solving. They are actually discussing things with each other. And so a lot of the education theories, especially adult education theories, were applied. So as of 2020, I guess I should update this for 2021, but as of 2020, we had graduated 4 classes because the training program is 18 months long. And there were 24 ECHO officers by end of 2020. And actually, I think about 2 years ago, we got formal Ministry of Health approval for this program, which, if you know how things work sometimes in these settings, that in itself is a minor miracle that all the bureaucracies of government were able to move forward with this. And so now it's an officially recognized training process. And actually the hospital is able to benefit by having all of these initial classes be faculty now for the new program, and now they take in a new class of trainees every year. I want to present to you some lessons and challenges, because I think for those of you, if you've not worked in these settings, some of these things may not be so obvious, although I think for many of you this will sound very familiar. But one of the lessons that I came across very quickly is the fact that we do not have respiratory therapists in sub-Saharan Africa. So that has huge implications for ventilator management and just airway management in general. But one practical thing was I was getting paged to run down the hill to the ICU probably every other day because of a situation like that that you can see, which is the plugged endotracheal tube. And I should have, I think realized right away what the problem was, but it took me about a week and 3, sprints down the hill at my age to figure out that because there's no respiratory therapy, nobody was at the time thinking about humidification. So it's something that I'd always taken for granted in the US because it's automatically done for us. But I failed to recognize until I got tired of really running down the hill. And so we ended up exploring things like humidifiers versus HMEs. And we ended up choosing HMEs mainly because of maintenance of sterility. But that was something that we had to work out through our colleagues and through input from our respiratory therapy friends, as well as taking into consideration the local supply chains. The other one is, I think, something that that many of you can relate to, is the cost of critical care is obviously not trivial in the US. And although things are cheaper in sub-Saharan America by American standards, it isn't necessarily cheap by local standards. So here is the annual per capita health expenditure in some of the high income countries like Japan, the UK, and the US. In Kenya, this is the per capita annual expenditure. It's only about $45. So obviously that is not much money that an average person in these countries have for healthcare expenditure. So with that in mind, the fee for a mechanically ventilated patient at Kajabi is about $90 a day. So it's essentially 2 people's annual expenditure to take care of them. And so figuring out who to help, and to when to have the end of life discussion is both ethically and logistically very challenging. And a related lesson is what is referred to as the fixed budget effect. Again, I think many of you are experts on this concept, but for those who may not be, this is an interesting concept. So if you consider a standard treatment, let's say it costs theoretically $10 a person, and it has a 50% cure rate. So out of 200 people treated with the standard therapy, 100 would be cured. And you're starting out at this point of neutral cost and benefit. So this is where you are in terms of the cost benefit analysis. Well, a lot of things that I had to wrestle with is there's of course, constantly better treatments that may be available. So if you consider a new therapy here where it's more expensive, it's $12 instead of 10, and it has a higher efficacy rate where 55% of people would be cured. So this is 110 now out of 200 people. And let's say a high quality study shows that this is a statistically significant improvement in outcome. So this is something that is commonly occurring. And so then if you were to ask yourself, now that you have a more effective therapy but higher cost, where would you be in relationship to this black original dot? Would you be in A, B, C, D, or E? And I think most people would realize, well, it looks like it costs more, but you get greater benefit. So you're probably moving from the black dot to something in this right upper corner, maybe something like A. But because of what's common in low middle income countries, which is a fixed budget, If you assume that, let's say, some donor made available $2,400, just for the sake of this example, but another problem in low middle income countries is that there are many, many more potential patients than we have the space to treat them. So if you have 400 potential patients and you have this money to spend on behalf of this particular illness, think about what would happen. Under standard treatment, if you have $2,400 and it costs $10, then actually you'd be able to treat 240 people. But with a newer, more expensive therapy, because it costs $12 instead of $10, you'd only be able to treat 200 people. And then if you take the cure rate, which is 50% versus 55%, the number of people who would benefit is actually lower than with the old treatments. And so this is the constant situation that we're running into, that we have to refigure for the local economy what actually makes sense, which drugs to bring in, whether it be comparing norepinephrine versus dopamine, for example. It's a dilemma that I think hardly anyone in the US has to think about. But in the Kenyan context, this is a real challenge. So the answer here is actually you're moving from the black dot to actually less benefit leftward. But because of the fixed budget, you're actually spending no more or no less. So you're actually moving from the black dot to C, which is somewhat counterintuitive if you're not considering the economic realities in a low middle income country. Another lesson that was very common for me is the Abcde Bundle, and it's a little bit different than the ones that we're taught here in the US, where the E really stands for equipment failure. So here's an old 900C ventilator that we used to use, and as you can see here, it says the inspiratory tidal volume is 408 mLs. And so let's assume that's 6 cc's per kilogram for your sick patient. And this is pretty routine. That in the expiratory tidal volume, however, was actually 1,579 mLs. And so, ventilator malfunctions, ventilator miscalculations, when I get a plateau pressure of 15, I can't tell whether that's a real pressure or some kind of an artifact of the malfunction equipment. So this is something else that is a constant battle, is to figure out what machine should we actually use, what's actually, what can be sustained and maintained in sub-Saharan African context. And so in the case of ventilators, we actually ended up getting refurbished ventilators from Europe and from India. And that helped out tremendously because they were actually quite affordable compared to a new ventilator. But it helped us overcome, these clinical dilemmas that arose because of equipment malfunction. In terms of resources, just to put your mind out there, it's not just the clinical resources that I'm talking about. Part of resource building actually included bringing in more robust Wi-Fi into this setting. So I was fortunate to have some help from the NIH, where they helped me find this little white tower, which is a receiver dish for Wi-Fi. And the importance of that for education is that it was hard for us to have a robust educational system until we built an infrastructure like that. So what that allowed us to do is have the learners who would be able to come to my house. This is actually my living room. And then this is actually our patio, where they're able to actually use mobile devices to look at lessons, to interact with one another. And then this is actually them listening to a lecture of a lecturer from Boston who was giving a remote talk about mechanical ventilation. So something as basic infrastructure may not be part of what you might think about, but actually, having some help and then having some basic things like Wi-Fi can really advance your educational agenda forward. This is something that I'm sure you're all familiar with, but this is a study back in 2003 talking about where do our biomedical papers come from. And as you can see here, most of the papers come from North America or Europe, 35% from Europe, 45% from North America, and Africa, as you might suspect, is not even 1%. So it's really an important thing that we are trying to address because, as you saw, the disease burden is actually the highest in sub-Saharan Africa, and yet the research that's coming out is also the thinnest in sub-Saharan Africa. And so, of course, some knowledge is transferable, whether it comes from North America or to Africa, but obviously there are some unique diseases, and there are local differences even for something like sepsis or ARDS that may be relevant in African context. So part of our education was not just clinical education, but is trying to build the research infrastructure for our hospital. So these are papers that you're all familiar with. So this is just a recap. But I think in the global health context, I think this is very interesting. If you recall, the initial paper by Dr. Rivers in the New England Journal of Medicine in 2001 was a study that involved 263 patients. It was not a registered study because it predates that expectation. It's a single center study with a conflict of interest in terms of the authors being involved with industry. And so a lot of markers of studies of bias here. And then, as you know, they were advocating an aggressive resuscitation strategy called the early cold-directed therapy. Well, again, I'm sure you're well aware of this study, but this is a study that came out of sub-Saharan Africa 10 years after the original Manny Rivers paper. It was a much higher quality study. It was registered as is expected, much larger patients, multi-center, without a conflict of interest. And in contrast to the Manny Rivers paper, it actually was associated with higher mortality if you gave these children in sub-Saharan Africa a fluid bolus. And so, of course, when this paper came out, it wasn't clear, is it because it's children as opposed to adults? Or is it because something unique about Africa? Or was it something else? But I think, as you know, subsequently, 3 other papers, including the process trial, which is, again, a very high quality multi-center trials, ultimately showed that the Manny Rivers approach did not improve survival. The more important point for me is that here's research coming out of Africa who, in some ways, we from high-income countries were actually bullying the low-income countries to adopt our strategy and our understanding. But when they studied it, they actually found opposite findings to what we were experiencing. And then very similarly, here's a paper by Ben Andrews in JAMA in 2017, which is looking now at adults comparing early and more aggressive resuscitation strategies versus what they call usual care, because in this setting, even fluid boluses is actually not trivial costs for some of the local economies. So IV setups and fluid boluses and all of that, and certainly vasopressors can be very expensive. So in their study, when they compare the protocolized approach, they got more fluids, they got more vasopressors compared to the usual care, but they found again a worse outcome, including hospital mortality with aggressive strategy. So again, it's not clear whether this is because African patients are different or something else in the study design that's showing different findings. But I think what it does emphasize is that there's a need for research to come out of sub-Saharan Africa, not just from wealthier settings. So as I try to wrap up, that has been our effort, and part of what excites me to be at the NIH now is we're starting a consortium called GC3, which is the Global Critical Care Collaboration. And the consortium is really centered at Kajabi, where we have, I think, a pretty healthy infrastructure for continuing our collaboration. But we have partners from 6 other better equipped universities and hospitals, including one in Kenya in Nairobi. It's called Aga Khan University Hospitals. It is probably the wealthiest and the best resource and the most academic hospital in Kenya. And so we have partners there who are helping out, but we have other partners from Beth Israel Deaconess in Boston, Mayo Clinic, NIH, some of my old colleagues in Pittsburgh, and then at Texas Children's or Baylor. And you can see the various people here. So we have representation from Kenya itself, but also from the US. And our aims are to help out in those ways that I've already outlined, which is a clinical care by sending ICU fellows and ICU attendings to Kajabi, and then to be part of a capacity building mission in terms of education, clinical resources, and for research. One important goal that we have is we are trying to send both fellows and attendings from our collaborative institutions. So let's say I go and I bring a fellow, and then let's say 2 fellows go with me, and then hopefully somebody else from Pittsburgh will do the same thing, somebody else from Mayo will do the same thing, etc. So our goal is to try to provide roughly 1 year's worth of clinical service to Kajabi ICUs. And part of that is not only to help with clinical care, but we want all of us who go to be part of the teaching team, so we can teach them ultrasound skills or mechanical ventilation skills and so forth. But more importantly, we actually are trying to give them academic protected time for Kenyan colleagues who are interested in learning about research. So some of our partners are primarily researchers who want to do projects in sub-Saharan Africa. And our goal is to essentially buy them time by us volunteering so that they will have protected time so that they can invest in coursework and they have the time to build databases and to ask important research questions. And our goal is to have a mentored research team in Kenya that we can build toward independence over the course of 10 years or so. We also have the great fortune of having Jason Brotherton, who is currently a 2nd-year critical care medicine fellow at Pittsburgh. And I give all the credit to Pittsburgh here, where they were supportive enough to allow him to do his 2nd year of fellowship almost entirely in Kenya. So that he's actually overseas and he's actually already contributing in this way. And his plans are to actually remain there after his fellowship with his family, so that we'll have a 12 months a year presence with an American trained critical care specialist. And we're working on housing for visitors in coordination with Dr. Brotherton. So, this paper, actually I mentioned earlier, talks about how in the developing world, even if you have interested people who want to do research, they actually lack protected time. And there's also lack of trained researchers who can mentor them. So that is one of our explicit goals of our collaboration. This is a statement that you may be familiar with. It's put forth by Annals of Internal Medicine, the American College of Physicians in 2018, and they highlight 4 sort of standards that they would like to have global health efforts meet in terms of standards. They're obviously too small for you to read here, so let me highlight a few of those and what we're doing to try to meet them. So one of them is the primacy of well-being of patients and the host institution. So that hopefully makes sense, is that we want to make sure that whatever it is that we're doing actually benefits the patients and the institution at Kajabi. And I think the research details that for high-income country volunteers, global health efforts are often very beneficial. It's motivating, it's inspiring, it often changes their career path and so forth. But unfortunately, the research does not show such a clear benefit for the low middle income country hosts in terms of what they gain from this. So this is something that we're trying to make sure that we approach cautiously with our Kenyan partners. The second standard that they put out is that we as visitors to a low middle income country are a minimal burden to host community and host institutions. So that could be something like us being a financial burden to them because we're there in terms of housing, food, etc. But even something like, because when we are there, let's say somebody else has to be pulled off of their regular duties to translate, to help us get acclimated to the local environment, etc. That could be a significant burden on the host country. And so we are actually working on housing by trying to create housing that minimizes the burden on the host institution. And all of the people who come from these 5 non-Kenyan universities and hospitals will be responsible for our own expenses. The third goal that they put is to make sure that we are sensitive and respectful of the local culture, which again, I think everyone would agree with. And so as put forward by Dr. Whitehead and others, we are approaching this as invited guests, and we're expected to behave as guests, which is obviously to be respectful of the local cultures and customs. And finally, they want the burden of pre-departure preparation to be on the high-income countries, where we prepare our own fellows and new faculty to go. So in terms of all the logistical challenges that we might face, ethical challenges from being in things that we're not familiar with, and so forth. So we have actually put together a curriculum for our future volunteers, and then each of the faces that you saw earlier, we're going to be the mentors for our own institution, so that new faculty and new fellows who come will be mentored by us, so that there's a proper orientation and training. Then at Kajabi itself, at the low and middle income country, also there's going to be a mentor there who's going to oversee how well they're doing in terms of acclimation to the new culture. This is my last slide, I believe. This is also a bit more expanded discussion about ethics of global health. As I alluded to earlier, I think a lot of good things can happen through global health, but it's also clear that a lot of harm and suboptimal things can also result. And so here's a paper that outlines some of those discussions. And so what we want to avoid are global health that happens because it sounds or seems glamorous to people, or because it's trendy, or a sense of adventure, frequent, flyer miles, all the secondary gain kind of stuff. There's also some accusation that some of us go because of our desire for poverty porn, if you will, out of sense of superiority or neocolonialism. And these are all serious things that we want to thoughtfully approach in our group. And then things that are probably less objectionable, that may be motivation for why we want to do this. It could be a sense of a deeper purpose or meaning in life, or meaning or meaningful work, because the clinical experience itself is interesting. And then just, like general exposure for all of us as human beings to the realities around the world. I think these are, maybe a bit healthier kind of motivations. From an institutional point of view, I think more and more fellowship programs are realizing that it's actually hard to attract applicants without a healthy global health program. So I know that I've been approached by many institutions to say, hey, what are you doing? What should we be doing, et cetera. And also some hospitals, like to market to patients that they're involved in global health, because it sounds like a benevolent, kind thing to do. So all of these things are great things, and I think it's stuff that you can use for like for your own institution. But what these things fall short of course, is that these are all directed at high-income countries. These are high-income country volunteer motivations or high-income country institutional motivations. So we hope to move beyond just those. I think these are still good motivations, but it shouldn't be limited to just high-income countries. But we want to make sure that we are being actually helpful to the lower and middle-income country hosts. So we want to make sure that we're able to improve clinical care, like I said, but also capacity building for education, resources, and research, and that we be a much better citizen of the world, where we can advocate for justice and for the sense of common humanity, and also that there will be mutual learning. Not only are we helping the Kajabi Hospital in Kenya, but we hope to be learning from them as we are able to apply what they do well to high income country settings, and also have a better understanding of the social determinants of health that we may be not paying attention to. So I think that's it. So maybe I will stop and open it up for any questions for the last maybe 10 minutes or so.
Dr. Lee, I just wanted to say thank you again for that. That was a fantastic talk. Really incredibly inspiring. The work that you've done in Kajabi is amazing, and it sounds like you've taken a lot of steps to really expand the capacity for critical care there. There are so many issues that you brought up, things to think about beyond just the medicine, everything from economics to our ethical obligations when we go, the cultural differences. And these are things that I think we need to think about here, starting a fledgling program in global critical care. Maybe I can ask you a first questions and then open it up to others. Given that we are just sort of launching into this for the first time, I wanted to get any words of advice that you would have. Oftentimes, as I think a lot of people might dream about spending a year or 6 years abroad, but family commitments, their commitments to job, sort of all impact their ability. And I wonder sort of how can the Institute best support faculty who are trying to balance personal responsibilities and jobs here with a desire to work internationally and contribute?
Yeah, that's a fantastic question, and I get asked that quite often. I think my answer is a realistic one, which is, not every institution is going to be supportive of this kind of effort, because quite realistically, if you send somebody off for a year of a sabbatical time, that is a huge cost to the institution. So I think we should be, realistic and saying that not every institution is going to be able to do that. However, I think there is more institutions than you might think on the surface, because I think there are many good can come out of this, and this can be a win-win for both the high-income country institution as well as the low and the middle-income country institution, and I think it could be a win-win for the person who is also who's also doing this, and I think the benefit is not limited just to the professional help that you can offer, but the benefit is just a personal growth element, like for you as a physician, but also just your entire family. My kids, essentially spent all of their teenage years in sub-Saharan Africa, and they still talk about it. They relish those moments, and it has really shaped who they are. So I think it's not a matter of like sacrifice, which is how some people might think about it. I think it's actually more of a real gain for the person doing it. So I would encourage people to think about not only what you might be missing or what you might be not able to accomplish by doing this in terms of your career, but also what you might be able to gain. And then the last thing I would say is I've been surprised at how accommodating institutions have been. I can't say that's the case for every time I've asked, of course, but each time that I've asked is usually after I feel like I've done a good work in my local institution, so I have the confidence and the trust of my boss or bosses, and then whenever I approach them about ideas like this, I think generally speaking they've been very, very supportive. So I would encourage all of you to, obviously, like to be in good standing in your own institution first, but also it doesn't hurt to ask. I think the worst thing they'll say is no. So I would just encourage you to take a chance.
That was wonderful. I have a couple of questions. One is, any ways of looking at generating money, like the Gates Foundation, because they're interested in global health? Because clearly, as much interest as you may have, it may not be possible to do this. And institutions in America probably have more resources than other places, but so you have to convince them that that's a good thing to do. And not just for marketing purposes either, but because it's a wonderful experience. So if fundraising is critical, because without money, you just can't do any of this stuff. You can't even build the institutions or buy the ventilators and whatever. But I wondered also that a big part of care of patients is nursing. And I wondered whether nursing training and nursing was part of the program here, because it's great to have docs, but they don't nurse. So that's a whole nother package. And I wonder how much effort goes into that component. And then the last thing is actually related to differences in outcomes between that population and maybe this one. And that is what I call the nutrition base. The nutrition base of the average Afrikaner may not be anything like the nutrition base in other countries, and whether that will offset the degree of inflammatory response that they will have to a critical event, which will alter the outcome. So the research may have to go into that pre-ICU period when you're looking at what the nutritional index is of your population base.
Yeah, wow. Thank you so much for those really excellent questions and comments. Let me start off with the one that gets me most excited, which is the nursing component. So I didn't talk much about that, but I give a whole different talk just about nursing. And also, whenever I'm approached by other enthusiasts who say, hey, I want to start an ICU, or we just started one, what do I need? And one of my standard things that I say is, actually don't build an ICU, but start training nurses to start caring and recognizing critically ill people in the setting that you already have. Because without nursing, you really don't have an ICU. I mean, you have a lot of machines that's going to sit idle and probably go unserviced and become out of date very soon. But you will not have an ICU. So I totally, absolutely agree with that. Actually, fortunately, in my situation at Kajabi, there's a long tradition of having a nursing school there already. And then there were actually nurse leaders who are all Kenyan, who has been outstanding in training nurses. The problem that we did run into nursing-wise was that there would be a significant brain drain, however. That is what would happen is, I think the hospital did an excellent job teaching nurses. They loved their experience at Kajabi, but then, since the capital city is only an hour and 45 minutes away, as soon as we trained them, all these private hospitals that had a lot more money than we did would actually scoop them up. So I can't blame them because they were outstanding nurses. But yeah, but I think training and then figuring out, ways to train and maintain the nurses is a huge challenge. And so whatever resources and thought you can put into that, I think is really, really necessary. So I wholeheartedly agree with you there. As far as your comment about research and then, the aspect of nutrition, once again, I totally agree with you. And I think that's the reason why research needs to happen in that local setting, not just take principles that seem to work in the US or in Europe and then just simply saying, we're going to do the same thing. I think, I'm just sharing, in my talk, just a couple of examples where there's a contradiction between what we think we know in the US, versus what happens in Africa. But I think there's many other examples of that. So I think a local research is really a high priority for our group.
If I may, this is such an excellent and deep topic that one can do 1 or 2 years of fellowship in it, if not another hour of Q&A. So I'm certain there are lots of people who have questions. Unfortunately, right now our next meeting starts. so we'll have to close it. I'll just have to say that you're going to have to come back, and not only as a speaker, but really as a liaison to help us build our program. Finally, as an Indian American, I will say to my American friends that before one becomes a global physician, one becomes a global human being. And it is amazing, as you pointed out, how much one can grow just by spending a year or two outside, the North American continent. It is an amazing experience for those of you who have the bandwidth to do it, spend a year or two outside. And then finally, about brain drain, we have all seen what it has done to nursing in the Philippines and India. Thankfully, they have deep pools of such talent. And, Africa is a little more under-resourced because I have spent some time there as well. Anyway, thank you so much, Dr. Lee, but this is not a goodbye. This is come back soon until later. Hasta luego.
Okay, and can I say one last comment?
Yes, sir.
Dr. Lee, Sam Aqua, I want to say a big habari and asante sana.
Karibu sana.
Okay, thank you.
Yes. Thank you so much for inviting me. It's been a pleasure. Thank you.
What a pleasure. Thank you.